Today's episode is kind of special to me. When I was venturing into hernia surgery, I came across this platform, Virtual Hernia University, where I first heard Dr. Malsher, and I have learned a lot of basics and advanced principles of hernia surgery from him. Since then, I have heard him over different platforms, including in RHSICon. It's really a privilege to have him here. He is a master educator, a lifelong learner himself. He has a load of publications. He has worked in different countries under different set of circumstances. So he brings a very rich experience to the world of hernia surgery. I'd let Dr. Sandeep Dave, who's our host for the evening, tell you more about him. I really want to thank Dr. Dave for so graciously agreeing to host the event. We all know him. He's our mentor and he's the past president of our society. And he's responsible for steering us in the direction where we are headed right now. We all know him. He's at present with very frequent and very quality academic activities. This program itself is the brainchild of our current president, Dr. Ramesh Agrawala, and I'm really happy to be a part of this entire series and seeing it become so popular and adding so much quality to the HSI academic activities. I will not take a lot of your time. You are here to hear Dr. Malsher and Dr. Dave. So with that, I hand over the platform to Dr. Sandeep Dave, sir. The stage is all yours.
Thank you, Palvi. Uh, I welcome Dr. Ramesh Agrawala, Dr. Flavio Malshe to this lecture series which we have organized on the platform of Hernia Society of India. I'll definitely like to say a few words about Hernia Society of India, which is one of the oldest society of its kind and with the largest number of members in the society, approximately 900 plus members in this, which was formed in September 2004 when like-minded people joined hands together and their brains together to form a society where everyone can learn, relearn, and go continuously. A platform was created where new enthusiastic surgeons were coming forward and learning hernia surgeries. Uh, Dr. Flavio, you will be surprised to know that that this society under the leadership of Dr. Ramesh Agrawala has done tremendous work during this lockdown period, where we have conducted master series and a lot of hernia programs, panel discussions, and this uh, series, which is the third episode of the hernia prime time, being conducted by Pallavi, is a great grand success. With these words, I'd like to introduce Dr. Flavio Malcher, who is MD, MSc, and FACS, graduated in medicine and general surgery, has done residency in Federal University of Rio de Janeiro, residency in minimal invasive surgery from the same university, master's in science in minimal invasive surgery from the same, and at present he's director abdominal wall program, Montefiore Medical Center, Bronx, New York. He is assistant professor of surgery at Albert Einstein College of Medicine, Bronx, New York, and he is also governor of America's Hernia Society. We are all here looking forward to hear about your experiences in inguinal hernia repair. So, Dr. Flavio Malche, the stage is all yours. Welcome, sir.
Thank you so much. It's truly an honor and a privilege and a pleasure to be talk with my Indian friends. I'm not surprised uh, because of your organization, our society, being at India twice and have opportunity to interact with you guys several times for the last years. I truly believe in potential that your country, your nation has. Um, you have the numbers, you have the will. I just hope that you guys can organize yourself in some kind of registry and just publish your experience. I see so many good surgeries, ideas, and concepts coming from India. I just miss that you guys come together and publish and show the world the potential that you guys have. It's amazing to see when I go to India or I talk with you, we discuss some concepts, and few months after, I see so many surgeries, ideas, and new concepts flourishing from this discussion. I think you guys are innovators. You are not afraid to try, and I wish all the best for you. And really, just show the world how big nation you are and how big School of Surgery India should be. So I put up this talk. It's something that the Brazilian College of Surgeons asked me to put together on my whole experience throughout 2 decades. It kind of tells everyone my age, because if someone has 20 years of experience in something, I cannot say that I'm 35 anymore. I need to admit my advanced, a little bit more advanced age. But for the full disclosure, this lecture will be my own take of what happened on inguinal hernia repair over the last 20 years. I'm not here to defend A, B, or C techniques. I'm just trying to show to you what was more or less published on those 20 years, and how I understand and accept this into my practice. I do have some disclosures to do. I consult for several industry and a few mesh companies and Intuitive, so there is some conflict here. I'm going to talk very, very briefly about meshes, not specific in 1 or 2, and I'll talk a little bit at the end about robotics, so I need to do those relevant disclosures. Hernia is not something new. Hernia is something that happens with our species for thousands of years. The oldest hernia patient that I saw any mention was when I was in Cairo personally visiting the museum, and one of the mummies died from a hernia that is 5,000 years ago. So you can try to avoid hernias, but the hernias will not avoid you. So even on vacations, you're still thinking about hernias and seeing hernia patients. The management of hernias was completely non-surgical for thousands of years. We were not able to operate and to cure, so different therapies were tried, and those binders and fosters were trying to be used to just to hold everything inside. 500 years ago, surgeons were trying to operate hernias, and those drawings are for almost 500 years ago, and showing how hernia was operated. As you can see, there was needed more anesthesiologists than surgeons, because there was no anesthesia. We just need to hold the patient. And you see the surgeon is not that stupid, because he put the patient in Trendelenburg, probably to minimize blood loss. And then the surgeon is super happy to see that some patients survive. I don't know if the patients are happy, because at that time, hernia could only be treated with orchiectomy. And you can see, I think the bilateral hernia guy is less happy than the unilateral hernia guy, because at least he saved one test. That all changed almost 200 years ago, or 150 years ago. Eduardo Bassini was really the first that published a decent technique that on his hands had good results, but at least he studied anatomy and proposed some anatomical repair to close that floor. And what we have left over from those non-mesh techniques worldwide is Shouldice technique, something that I've done a few cases. I'm trained to do, but it's not really my practice. I understand that different parts of the world, we have different non-mesh techniques, but what we have accepted worldwide as the only surviving non-mesh technique is the Shouldice one. We have all those different mesh techniques. I just mentioned Felício Fauci. He was an old professor of surgery in Brazil. He did publish a mesh in the groin way before Liechtenstein, but in Portuguese, it didn't get the world, and it's kind of a modified Liechtenstein, if you can play so. But what we all know as the standard open mesh repair for inguinal hernia is what we call Liechtenstein repair, published almost 40 years ago. It has been modified through the year, and I'll touch this. But let's start my journey of 20 years. So as it was mentioned on the introduction, I graduated and I did my general surgery training in my university hospital, the Federal University of Rio de Janeiro. That's the picture over there. And that at that time, exactly 20 years ago, I was finishing my residency. What I learned in my residency: the standard of care for inguinal hernia was the Zimmermann repair. Zimmermann repair is a modified Bassini. Instead of suturing the conjoint tendon to the inguinal ligament, we suture the conjoint tendon to the iliopubic tract. It's just a little modification of a Bassini. And that was what I was taught 20 years ago. Not 40 years ago, but 20 years ago, the standard of care, one of the most important procedural residency programs in Brazil, was Zimmermann repair. We were taught on McVeigh repair for femoral hernias, and I did see some Liechtenstein repair on my residency. It was nothing forbidden, but MASH was so expensive, and MASH was reserved for recurrent hernias. So the hernias that were recurrent after any non-MASH repair, we did use Liechtenstein technique to repair them. Some attendings use Fauci repair, but it's pretty much the same, just some minimal modifications. So that's what I start to be a surgeon. My early career, I'll say in the first 10 years of my attending career, I worked in 2 private hospitals that you can see on the top, and one little county hospital in Rio de Janeiro. And as a side note, I was 29 years old, and by politics and every other surgeon on the hospital, they fought between themselves, and I was the youngest surgeon on the hospital. And after 6 months in that hospital, I was promoted for division chief because nobody wanted to be division chief, and I was the last choice. That hospital has no ICU beds. We just did like hernias, lap cholis, some thyroid, and some very selected gastrectomies and colectomies. And I said, okay, let's do this. And I started promoting courses of hernia repair at that time. And that's what really got me started on the hernia business. And I work a lot with JJ, with PHS, and some other techniques. But I saw some lap inguinals on my private practice, but it was very painful at that time. When you see, when you book inguinal hernia, you say, oh boy, again, and spend like 2 hours trying to find your way. It was painful, and I was not training formally on my residency on lap inguinals, and I did my fellowship afterwards, and that's when I started doing more and more. Let's do a parallel where I were in my career and what was being published regarding inguinal hernia repair. At that time, 20 years ago, we still have some discussion about MASH or non-MASH repair, and some systematic reviews were published showing that we should use MASH to repair inguinal hernias in adults. One from Cochrane and one published in Annals of Surgery always say, I'm sorry, I forgot to translate this slide, but all saying that MASH reduced recurrence and then did not increase complications. And at that time, I said that the MASH made bad surgeons look good, look to be good surgeons, because if you really want to have good results without a MASH, your only chance is if you have a very adequate operative technique. With MASH, if you put a MASH on the groin, it can be a Liechtenstein, can even be a plug. You can modify Liechtenstein, but you have a pretty high chance of have a good outcome regarding recurrence. I'm not going to talk other complications, but regarding recurrence, if you do somehow a MASH repair on the groin, you have over 95% chance of have a good result regarding recurrence. And that was kind of convincing me that we need to use MASH. At the same time, we have more and more publications, and most coming from Germany, showing that hernia is not only a mechanical disease. There's something happening with the patient's tissue that does not bring a good tissue repair, a long-standing survival. So that was when I started my career. I understand that I need to do MASH in everyone. I think I never done a non-mesh repair after my training unless it's a very specific situation. And I really work as a surgeon using mesh for repair in the inguinal hernia. And I will just do a giant step on timeline just to prove my point. Now we don't discuss anymore if we should not use a mesh. Actually, sometimes we discuss, but it's common sense that inguinal hernia repair in adults require mesh. And the last review that I found, another from Cochrane, just showing that mesh repair should be done over non-mesh repair. So discussing mesh repair, the Liechtenstein came to be the gold standard, and it was modified. This is one of the latest publications now from Dr. Amit, that one that followed Liechtenstein, that now is retired as well, showing that how the techniques change. And if you compare the two publications, one from 1989 and the last one from 2004, you really can see how Liechtenstein repair changed over the years. The mesh is much bigger. You don't have the running suture over the internal oblique conjoint tendon as it was published by Liechtenstein initially. You have much more pubic overlap. You have identification of the nerves and preservation of the nerves, all these little details that can make the whole difference. So don't take for granted that you do a Liechtenstein. Go back to the region technique, or not the last published technique, and review it. And when you dictate that you do a Liechtenstein, really do a Liechtenstein. Don't do your modification, or if you do your modification, dictate that you did a modified Liechtenstein. So just learn the proper technique. So we are between the 2000 and 2010. I'm starting my career doing a bunch of Liechtenstein. That's what I believe it. And we start seeing some reports and publication of lap inguinals. And some trials showing that maybe in proper hands, you have the same results with less complications and earlier return to activities. This is another Cochrane review showing that takes longer. You can have more major complications, mainly big vessels injury, but the patients do better with less pain and return faster to work. So in my private practice, when we have a lawyer or a physician that want to go back faster to work, I start to try to do lap inguinal repair. But at the same time, my senior partner, and I love him to death, I consider him my oldest brother. He walked around with this paper that was published on New England Journal of Surgery in 2004, and showing that we have much more recurrence when we do lap inguinals than we do open inguinals. And that paper was a really burn to our attempt to improve the numbers of lap inguinal repairs. But what people don't do is read carefully and truly the paper. If you read that paper, you will see that you have less experienced surgeons with less than 250 repairs on the same paper. You have over 10% recurrence rate. But if you do analyze only the experienced surgeons over 250 repairs, you have less than 5% recurrence rate. What was the same on the open recurrence rate from the open group. And that's another side note. If any of us publish a 4% recurrence rate after Liechtenstein, everybody will criticize us. Liechtenstein should give you 1 or 2% rate of recurrence. So there's some flaws on this paper. I don't want to judge technique, but it, for me, proves that experience is needed for lap inguinal repair. So when did I really discover lap inguinal repair? It was 2005. I can remember the day. I was one of our national meetings, surgical meetings of Brazilian College of Surgeons 2005 in my city. And I attended a master course from Dr. Sergio Hall on TAP. All my lap inguinals were TAPP, transabdominal preperitoneal. That's usually how we learn in Brazil. And I saw Sergio performing taps and teaching taps. And for me, it was a game changer. That makes much more sense to me to do a TP than go inside and then come back. And I taught myself, to be honest with you, I have no mentorship. I just watch videos, study anatomy, and start doing my own cases. And I become one of the tappers in Brazil. It was only a handful of surgeons in Brazil that used to do taps, and I was one of them. And going forward on that decade, we start seeing more and more publications showing that really safe to do lap inguinal repairs. And that when on the first 5 years of this decade is when I start doing more and more lap inguinals, now taps. This is the guidelines of the European Hernia Society 10 years ago, showing that you take longer, you have less complication, less chronic pain, but you still need to learn properly and use big meshes. Endoscope was an option even from primary unilateral or primary bilateral. It was always been an option during inside the guidelines. At the same time, we saw this boom of different meshes coming to the market for open surgery. All these anatomical meshes that I told you, that I taught a lot of PHS. The plug, they were never a big thing in Brazil. Maybe in the United States, they still are a big chunk of the cases. And we start seeing those anatomical mesh and self-gripping mesh. They are not necessary for a decent lap inguinal repair. They do help. I like to use them because I'm a very lazy surgeon. I like to cut my work, and I love to do anatomical mesh. It's just easier to put. And self-fixation mesh, I use in specific situation that I want more non-traumatic fixation. And if you look backward, this publication is very interesting from 10 years ago, analyzing 20 years behind, not up to now, but up to 2020, 2010. And we can see that the surgery repair reduced drastically over the decades after Liechtenstein, from almost being the majority on the 90s to be exception on 2010. And the open mesh repair, it was kind of an exception before, and then become to be almost majority, and now decreasing a little bit. And lap inguinal, it was almost an exception and then raised again. So you can see those curves crossing, non-mesh coming down, open mesh coming up, and lap inguinal rising little by little. There was a bump here with several complications, and people understand. And those curves, I don't know, depending on the country, they can cross, but most of the hernias are still done open or worldwide. At the same time, I saw those publications about watchful waiting. That's something that changed my practice as well. I was taught that inguinal hernia equals operative treatment, surgical repair. Nowadays, we do know that it's pretty safe to just observe asymptomatic males. So it's something that changed my practice. I do this in a few patients. They don't want repair. And if a patient does not feel anything, I only can make his life worse. If I operate him and he has anything, any pain or anything, he's worse as he was before because he didn't feel anything. It's pretty safe to observe those patients. So let's move forward. Midterm, I changed jobs. I came to another university hospital. In 2009, I found with a few other colleagues, the Brazilian Hernia Society. And as you mentioned on the introduction, is a very productive way to improve yourself, is to be part of a society and discuss your experience with others, interact with others. And I learned and I developed myself so much after being part of an active hernia society. And I have all these fellows that were there with me, and you may know a few of them as Dr. Marcelo Furtado, Cristiano Klaus, Morel, Leandro Totti, Júlio Baiter, and Renato Miranda. Those guys really taught me, those two, Renato and Júlio, really taught me open surgery. Renato is an expert in Shouldice repair. Júlio is an expert in Stopa repair. Those are more minimally invasive surgeons. So it was a very beneficial to myself to be actively engaged in a hernia society and learn from my peers. I think this is key. We cannot do our job by ourselves. And the Gafreguini University Hospital gave me the opportunity to improve my surgical skill in complex surgeon, in complex patients, and laparoscopy with low resources, because we did have laparoscope towers, but we didn't have a lot of disposal. So I need to taught myself how to navigate on this. Tap and tap start the debate. What was better? I want to speed up, so I don't want to take. I want to save some time for discussion. More and more papers were being published. Now bigger numbers is still showing the benefits of lap ingno over open repairs. Totti published on Surgical Clinics of North America in 2014 with Rosen his review saying that laparoscopy is safe, recurrence is about the same, less chronic pain, but it's key to have proficiency, to have training experience on those repair. Let's talk about a little bit about cost, and I apologize for those numbers. Those numbers are from my experience back in Brazil. If I do a tap in Brazil and I use a balloon, a fancy mesh, and a tack or a glue, I can easily expend high bucks on this, $1,500 or more to do this. It's almost prohibitive in our public system. If I do a tap, I can be a little bit cheaper and don't use a balloon and close with a barbed suture if I want to be fancy, but it's still a lot of bucks. But what I've done in my university hospital is tap without a balloon, telescope dissection, without fancy mesh, with no fixation. So I used to say that I was cheaper than Liechtenstein because I just used the mesh. I didn't even use the sutures to fixate the mesh. It's just my time. And that culminated with my master in science thesis that was my publication, Mean Laparoscopy, where I operate all those 60 patients without any balloon and without any fixation. And I was able to write this paper comparing mean laparoscopy with traditional tap, just showing that mean laparoscopy is a little bit less painful for the patient. Talking about pain, we don't have time to discuss this, but for me right now in 2021, my biggest challenge in my career is to manage chronic pain on post-inguinal hernia repair. So this is a real thing. We don't like to talk about it. People don't like to manage those patients. They are difficult patients, but now I'm much more focused on preventing chronic pain when I do an inguinal repair than actually prevent recurrence, because as I said in the beginning, the mesh will do the trick. The mesh will prevent if properly deployed. So where am I right now? I changed completely my career. In 2016, I moved to Orlando in celebration with Eduardo Parra Davila. I spent 2 years doing research, and then I became clinical back again here in Montefiore. Now nowadays I run a dedicated program. Our system does between 14 and 1,500 hernias per year. I do 250, 300 hernias myself every year. Half of them are robotic, and the rest is open and laparoscopic. But if I went over my own data, only inguinals, I almost don't do more open repair, only 2, 3, or 4 per year, just very specific cases. And half of them are laparoscopic and half of them robotics. Usually I do laparoscope for straightforward hernias and robotic for bigger recurrent or something else. My practice is very biased. People don't like to send me the easy cases. They always send me the harder cases. Talking about robotics, I was taught by Eduardo back in Brazil, and here you can see him with me on probably my first cases. I do think that is a role for robotic inguinal hernia repair. For sure, we need to discuss the reality of the country and reality of the health system. But nowadays I see a trend of, at least in the United States, more and more robotic cases are being done for management of inguinal hernias. This slide is a little bit old. Those curves already crossed it. As you can see here, there are more robotic hernia repairs being done in the nation than laparoscopic. And why that? It's simple. It's simple. The answer is very simple. It's easier to do a robotic inguinal hernia repair than laparoscopic. I'm not saying that it's better. It's easier. So if you are a laparoscopic surgeon and they give you a robot, you love it because it's just easier. You can do more complex cases. If you're an open surgeon and you try laparoscopic and you suffer, you struggle, they give you the robot, it's easier for you to do an MIS repair. So that's the answer is very simple. Why we have in the United States more robotics than laparoscopic repairs for inguinal hernias? Because it's easier, and cost is not a big issue because the system, the hospital system, they have the robots. And I could not finalize this discussion without touching the two main publications about MIS repairs: the Critical View of Myopectomy Number 5, the 10 Commandments. Actually, there are 9 commandments from Jorge Dias and Edward Ed Felix, and the publication from Marcelo showing the 5 triangles and anatomic review. So we sit down, we invite Jorge, we invite Felix, and we wrote the 10 golden rules as kind of joining the commandments and the anatomic review. And I don't think that we'll have time to go over all the rules, but how to start the surgery, to dissect the proper preperitoneal plane, adequate crossover and medial overlap, femoral hernia dissection and rule out, parietalization of the elements of the cord, posterior dissection to allow you a big mesh that will not fold, abandon the sac if it's necessary, rule out lipomas, minimal 10 by 15 mesh. Fixation is most often not necessary, but if you do want to fix, you really need to minimize fixation, traumatic fixation, and know where to fix, and finish the surgery properly with the deflation under review or adequate flap closure. The guidelines they were European guidelines, were republished as international guidelines a couple of years ago, and for the first time in history, it said that if proficient is present, if the surgeon knows how to do a proper lap inguinal repair and a proper open repair, he or she should opt for laparoscopic or robotic repair. The first time that it was stated, the same thing happens with the Brazilian guidelines that I participate. And this is just fresh out of press. It was just accepted. A survey that we applied, or almost 900 response from surgeons all over the globe. And the first time that I see this, surgeons are understanding what's going on, and 60% of the surgeons reply they would choose lap inguinal over open inguinal repairs. It was kind of surprising to me, and it's interesting to see that if you consider yourself a hernia specialist, you do more MIS for inguinal. If you don't consider you a hernia specialist, you do fewer lap inguinal repairs. So I'm running here to the end of the presentation. My final message is what changed my career, what changed my perspective is participate in hernia societies. Nowadays, I'm pretty active in those 2 hernia societies. As was said on the beginning by Dr. Priva, HerniaU is an online platform. We have IHC, we have several social media groups. It's a great way to learn. You need to be critic what we see. But it's a good way to learn by posting yourself, having the criticism, and understand what others are doing. And I put here as a reminder, follow your data. QC here, I'm a QC member. I put all my data in QC. You don't have to have a QC. You do your own data, your own follow, but please follow your patient. When you really follow a patient, you understand how good or bad you're doing for them. So how do I see hernia repair now after 20 years? If it is a straightforward hernia, a small hernia, and most of the hernias fall under this group, I do a tap. With or without balloon. Nowadays I do have balloon, but I don't think that's a must. And I do an anatomical mesh because it's just easier for me, but a flat mesh will do perfectly fine. If it's a larger hernia, but it's still reducible, I like to do E-tap, and just to give more operative field so I can do a better or easier job. If it is really large, I do heavy weights and I do some kind of fixation. If it's recurrent or unreducible one, I do robotic tap. If you don't have the robot, you can do a tap because you need control of the content. And if it is a gigantic hernia, really gigantic, those that go to the knee or poor candidates for general anesthesia or any other reason, those are the cases that I still do open. If it is a small hernia, Liechtenstein. If it is gigantic, a Stopa. Just for a reference, last year I did 1 Stopa and 3 Liechtenstein. during the whole year. But that's how I see myself now in 2021. But the real question is not how Dr. Flavio does, is how do you do? Where do you fit? And this is my final concept. If your practice is to do primary hernias, unilateral, bilateral, really day by day hernias, it's pretty okay to learn Liechtenstein and do Liechtenstein. There's nothing wrong with that. If you do have the skills and the opportunity, learn TAPP, learn TAP, and the patient will have less pain, but they will do fine as well. If you want to do something else, you want to start doing recurrent hernias or larger hernias, you need to learn some different techniques. You need to know, if you are an open surgeon, you need to know Nihus or Stopper. They're not easy procedures, but you need to learn them. If you are an MIS surgeon, you start to do some complex and advanced procedures like ETAP or TAPS, robotic TAPS. But at the end of the day, if you think that you are capable to do complex situations on the groin as gigantic loss of domain, multi-recurrent hernias, and chronic pain procedures, you need to step up to do pneumoperitoneal, Botox, neurectomy, complex repairs, and you do fine. My point is, not every surgeon needs to do everything. I know that every surgeon does hernias, and that's okay. I will do a parallel with the HPB. On the green will be the lap chole, the gallbladder. Every surgeon does a cholecystectomy, and that's perfect okay. Not every surgeon does a common bile duct injury. That will be the orange. Not every surgeon should do redo on a residual gallbladder. Not every surgeon is capable to do a very hard necrotic and gangrene lap chole. You should have some experience. And not every surgeon will do a liver transplant. It's not because we do gallbladder surgery that we need to learn liver transplant. The same thing applies to abdominal wall. Every surgeon should be competent enough to do a straightforward inguinal hernia repair, but you need to be honest with yourself. What are your limits? And not try to adapt the patients to your practice, but you do need to adapt your practice to the patient. It's okay to do simple cases. You can adapt a little bit to do more complex cases, but there's some cases that you should not try to chop the patient. You better refer the patient to a reference center or a specialized center, or become a specialized center and get the proper training and reference. So this is my final slide. Watchful, what I learned 20 years, watchful waiting is okay. Mesh repair, if you are proficient, MIS should be done. And at the end of the day, quality of life is what matters, and we should be responsible to our patient, understand our limitations, and give the best of us to them. Thank you so much. I'm sorry if I went over a little bit of time, but I'm super happy. I have nothing else to do this today. I'm all here for you. I'm happy to answer any questions.
Dr. Sandeep Dave, sir, you are on mute.
Thank you, Flavio. Thank you for this wonderful lecture. It has definitely raised our knowledge to a great extent. Your experience, your papers, your work has definitely helped us. The 10 golden rules which you have written, we have started following all those things now. And definitely we were following, but we were not practicing as you have defined now. Regarding registry, let me tell you one thing. Dr. Sarfraz from Kolkata has definitely done a tremendous job. Along with Pallavi, they have started a registry in which all of us are putting our cases, especially for ventral hernias right now. But very soon we'll be starting for inguinal hernias also. We have received many questions. The crowd was very interactive, and they have given questions to us also. One question which comes to my mind is, what do you think? Hernia as a surgery has seen so many techniques evolving, but still last word has to be defined, and last word has not been yet said about the hernia surgery. How is Lichtenstein placed in your practice? What do you think Lichtenstein is at present in your practice? Dr. Flavio.
The final word has not been spoken, and it will never be. We are involved species. When we think that we have the final word, we are going to prove ourselves wrong because something else will come out. And that's what makes us humans. We always search for something different answers. We are unquiet. The question is how I see Liechtenstein in my practice right now.
Yeah.
Yeah. Okay. So Liechtenstein is a good technique. As I said, everybody says that does Liechtenstein, but when you watch it, it's not really the traditional Liechtenstein. First of all, learn the original not the original, but the last published technique, the proper technique. And if you want to modify, that's okay, but state that you modify the technique. Works nice if you do a good pubic overlap, a wide mesh, minimal fixation over the internal oblique, and protect the nerves. It works fine. The problem is the pain after it. Here in the United States, my problem is the plug. I have so many plugs and so much discomfort after the plugs. But Liechtenstein works fine. I don't have any problem with that. I modify Liechtenstein in my practice right now. I use ProGrip mesh for Liechtenstein. With that, I do less fixation. My advice is what I learned from Mike Rosen. I don't do prophylactic neurectomies, but if the nerves are in front of me, I cut them. I don't search all the nerves. I don't want to do neurectomies but if during the surgery, the nerve cross my way and stay on my way, I don't hesitate to transect it. And I tell the patients they have some numbness after the surgeries. It is something expected. There's only modification that I do. I do prophylactic neurectomies more often, not routinely, but more often.
Okay. Regarding minimal access surgery for the groin hernias, you have started somewhere in 2000 or 2001, if I'm not wrong. Now, how your technique has evolved from TAPP to TEP, now ETAP and robotic. How do you evolve the technique? Now you have defined 10 golden rules also. So from the beginning, the first case which you have done to defining the 10 golden rules, how was the journey?
It's a very good question. So I remember the first cases, it was TAPP. I was just asking more experienced surgeons to come to help me. So painful to navigate through that anatomy. I remember I was not taught on that anatomy. I was taught on Liechtenstein, on Zimmerman. So I didn't know that anatomy. It was painful. The ergonomic, my shoulder hurt, and to close the flap, it was painful. Well, I remember when I booked one, I spent the week before suffering. Oh man, next week I have a lap inguinal. It will be painful. And then I found TEP, TAP. And for me, it makes all the sense. I always liked extraperitoneal surgeries. I did retroperitoneal adrenalectomies. I like to stay out of the cavity. Saves me time. Everybody thinks that is harder. I can agree with that, but once you get comfort on, I think it's easier to do TEP. So I watched Sergio Hall. I spoke with him. And I taught myself. I said, oh man, this is how it needs to be done. And I started little by little. I really only got a little bit more comfortable after 30 cases. And I started doing tap, 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 taps. When I was training robotics, I came back to the tap because robotics, you don't do tap, you do tap, but now you're comfortable. To sew is very easy. And I started doing back robotic taps and just make my life easier. Nowadays, and then ETAP came 3 or 4 years ago, and I'm very good friend with Jorge Dias, and he thinks it's for everything. And I don't think it's for everything. You don't need ETAP for everything, but don't be shy. If you have a little bit more a difficult case, a harder case, you do a ETAP. It seems silly just to change a little bit the port, but it gives you so much more space. So, and that's how I started doing ETAPs. So nowadays I do taps for my straightforward. I did 2 this week to teach residents. And the robotics I did one this week is for recurrent obese patients, more difficult patients. But it was quite a journey. And the 10 golden rules came from a need to try to make my life easier, how to teach this in an easier way, because we taught a lot over the years, and anatomy was always a struggle. That's why Marcelo published the inverted Y. And then the commandments, they are a great idea, but to join both concepts, I think that makes easier if we follow rules. It's just easier to teach.
Thank you. In our practice, we come across large groin hernias. These hernias are really difficult to tackle, and definitely in India, what we get is more often the large groin hernias. Now, in these hernias, how do you prevent mesh getting migrated? Do you close the defects, or what is your practice to manage these large groin hernias when you are doing it lap?
Nowadays, nowadays I don't do those large hernias lap because I have the robot. So I do robotic, I abandon the sac, and I try to close the defect. It's not standard of care, I do know, but I try to. But if I recall, you guys, Stopa, that was the standard repair for gigantic bilateral hernias, never closed the defect. The solution for the gigantic defects on the groin is not only the closure, actually is a large piece of mesh. So for me, nowadays, if I have a gigantic hernia, is a Stopa repair. Okay. So 30 by 25 mesh, all the way to the retroperitoneal area, all the way down to the radius, all the way up to the belly button. Big mesh, you stay in place, you not migrate, possibly.
Now, with the large hernias comes seroma. What do you do to reduce the chances of seroma formation? What is your technique to reduce the seroma formation?
There is no magic answer. I really change this. I don't try to reduce more large sacs. We've done this in open cases. Those gigantic sacs, I never reduce them. If it is really gigantic, I can partner with plastic surgery to do plastic scrotoplasty. But I just abandon the sac, and I have the feeling, just my own feeling, when you abandon the sac, the opening of the sac or the distal sac stays on the preperitoneal area, so the fluid can come out. If you dissect that sac and cut it deeper into the scrotum, the open end will be deep in the scrotum. So I think it's easier to close and form a hydrocele or a seroma. But it's not a magical answer. It's a hard thing to do. I still have seromas, but most of them I just don't touch. If it chronifies after 6 months, I go back to the scrotum and do a scrotoplasty and resect the now cyst, the insisted seroma. One bad complication that I got from my last year, I think that was my worst, is a lymphocele. It's not a seroma, it's a lymphocele on the preperitoneal space, and it was not a big hernia. I don't know what I did wrong. I already watched the surgery a couple of times. The patient has a huge lymphocele, and it's much harder to treat, and I'm still managing the patient. So not a seroma, lymphocele, and maybe I over-dissected over the iliac, something that I did wrong.
You're on mute again, Dr. Dabeso.
Sorry. Another question which comes to my mind is the meshes. Can you hear me now?
Yes, I can.
Yeah. So the choice of mesh for groin hernias, is it macroporous or microporous, lightweight or heavyweight or medium? It's polypropylene or polyester. And then along with the mesh, a very difficult thing which we come across is mesh infections. And that is a serious thing which converts a minimal invasive surgery to a maximal invasive surgery. How do you avoid it in your practice, and what you do if the infection occurs?
So regarding meshes, the porosity, we need to discuss, there are two types of porosity. One is the material porosity, and macroporous is all polypropylene mesh as a macroporous. There's no micro or mi polypropylene mesh. This is the material. The textile porosity is how the mesh is created. We have macroporous with a bigger, we can see the bigger pores and the smaller pores. I'm a fan of macroporous meshes, so I try to use bigger pores. I am not a fan of polyester. The only polyester I really ask you not to use multifilament polyester, because I've seen terrible infections. They don't infect more, but when it happens, is a nightmare. You never resolve them. The monofilament polyester I still use on ProGrip. ProGrip mesh here in the United States is monofilament polyester. Works as good as polypropylene. The problem is that some reports that are more fragile over time for ventral, not for inguinal. So I don't have a problem with monofilament polyester. My to-go mesh is middleweight polypropylene. And if it is a gigantic hernia as a stopa, when I don't close the defect, I go to a heavyweight mesh. Mesh infection is a real problem. In the groin is less worse. You have much less infection of meshes in the groin than in the compared with the ventral. If you do MIS, your mesh infection is almost non-existent because you don't have contact with the skin. The problem is when you have chronic mesh infection in the groin, it's a disaster. It's really hard thing to manage. I resect the mesh. I don't put another mesh. I allow the recurrence to come back, and after everything is sealed, 6 months with no infection, I will come back and fix the recurrence. But you can change gloves. Antibiotics for the regular lap inguinals are not necessary. We stopped using them a few years ago, and we haven't seen any raise on infection. But it's nothing wrong if you do want to do prophylactic antibiotics for lap inguinals. Thankfully, it's a very rare occurrence.
Okay. How do you deal with the recurrences? Recurrences are there and more often seen with inguinal hernia, groin hernia repairs in whatever way we do. If you have done a Lichtenstein, will you like to do a laparoscopic, or after laparoscopic, what will you like to do for your recurrences?
Recurrences are interesting because everybody states that we have 1 or 2% recurrence rates, but if you survey the service, everybody operates 15-20% recurrence hernia. So the math does not work. If everyone has 1% recurrence, how come everyone operates 50% of recurrent hernias? So recurrence is still a thing. I'm not saying the surgeons are lying. We just don't know that our patient got recurrences. That's why it's so important to follow your patients. My answer is not the board answer or probably the standard of care answer, but I'll give to you anyways. If I have a patient with a prior Lichtenstein or a plug and a recurrence, I do MIS. If I can, robotics. If not, laparoscopic. And usually the preparatory plane is fine. It's not a great deal after Lichtenstein. So a tap, or a robotic repair should be fine. If I have a prior posterior repair, robotic, laparoscopic, open, the board answer is to go open. But maybe I'm a little bit stubborn. Nowadays, I go robotic. It's my comfort zone. I feel that I have a more controlled field, and I've been able to manage those patients with a robotic repair. But the easier answer is, if you have a posterior repair, go back with a Lichtenstein and get the job done. The caveat on this is if the patient has chronic pain and recurrence. So now you need to plan your procedure to expand the mesh, maybe do an neurectomy, and then correct the hernia. So just be aware of this and plan you properly.
Okay. This may be the last question from my side. Pallavi and Ramesh might be having any questions to you. How do you see robots? You have talked a lot about robots. How do you see robotics in groin hernia repair? The future is of robots, or we are going to stick to this laparoscopic repair or endoscopic repair?
I mean, I cannot say the future is robotics because it would not be available for everyone in a short period. I don't see, even with the new companies that are supposed to come in the near future, I don't think the platform or the different platforms will be available to everyone in the next 5 or 10 years. Definitely is an easier operation to do. That's why I suggest everyone that has access to one to try it. Is just easier. It just expand your capabilities and so forth. I see more and more laparoscopic hernias being done. We understand how to make the surgery cheaper nowadays. We see more and more trained surgeons. We have publications to help us to be better surgeons on MIS. So I think the future is more and more MIS repairs, but robotics will take longer. It's not available for everyone.
Yeah, one more question, and that is regarding sliding hernia. What is your policy of tackling the sliding hernias, especially to reduce them, especially the urinary bladder on the right side? How you are able to reduce the urinary bladder? Is it difficult or it is possible at this?
I think sliding hernias are one of the most difficult situations, and we don't speak a lot about them. We don't pay enough attention for sliding hernias. I found them to be hard to operate, harder open. I only do when I do a robotic repair or a laparoscopic repair. It's easier to me to reduce the bladder from the peritoneum, from the hernia. To be honest with you, I find the sliding sigmoid and the sliding cecum much harder to manage than the sliding bladder. The bladder usually is not that hard. The sigmoid when it slides and the cecum when it slides are much harder to reduce. You can get easily lost on those planes because you don't have the hernia sac to guide you, and you just need to be sure where you are and avoid to make complication. But you are absolutely right. Sliding hernias are underrated, difficult situation.
Thank you. Thanks a lot, Dr. Flavio. Over to Pallavi for further activities. Pallavi.
Thank you so much, Dr. Sandeep Dave. Thank you so much, Dr. Malcher. I think we have addressed most of the important questions, and it was a really enlightening experience for all of us. I already am getting requests from people who have missed the first few minutes to put on the entire recording, so that tells a bit of. With that, I'll hand over the thing to Dr. Ramesh Agrawala, sir, for his opinions and his closing remarks. Thank you, sir.
First of all, on behalf of the Hernia Society of India, I would like to express my gratitude and thanks to Dr. Flavio for agreeing to spare some time and share his experience. And this has been a very, very informative and interesting talk. And I think you've covered it so well. You've been so candid and truthful. And certain places you've been, I can see certain things which you've done, which we've also done, is that we did not have any formal training in MIS. So we also looked, we had somebody to hold hands, we saw videos, and then picked up small hernias and moved forward. And I think that is the way forward. And what you've said is, you have to adapt, you have to know all the different procedures. And it's not necessary that you have to do MIS in all cases, but there are cases where you might have to do Liechtenstein, where you might have to do Reeve Stopa, or you might have to do robotics. So you tailor your thing according to the hernia. And I agree with you that India is a vast country. We have huge numbers, and the people are very gifted and talented, but we don't publish. So we've taken an initiative. We have another organization, Indian Association of Gastrointestinal Endosurgeons, and we've started a research group which Dr. Sandeep Dave has just spoken about, And now we've started, it's not exactly a registry because it's very difficult for a vast country like ours to have registry. And there is also a question of funding, which we don't have any government funding, and getting private funding becomes difficult. So we've started these multi-center studies. So one of the multi-center studies we've started is on ventral hernia now. It's going to be 1 month old. It's a 3-month data to see outcomes in ventral hernia surgeries. And we are trying to instill this, the culture of publication amongst our fellow surgeons. And I'm sure we'll be successful over a couple of months or a couple of years. But your talk has been really inspiring and interesting. And I myself have learned so much. And you can understand that so many questions have come. And our Dr. Sandeep Dave is a very prolific hernia surgeon. He's a master surgeon, and he's state of art, the APP repair. He demonstrates in all these national conferences, and he's a big hit. And I'm so grateful that he could take some time. He's gone there to meet his daughter, but in spite of that, he's taken time to be with us and share his experience. And Dr. Flavio, you can see how many people have been on the show. There have been so many questions. I think we've covered every part of hernia, inguinal hernia surgery by the questions. So thank you very much, Dr. Flavio. Thank you very much, Sandeep. Pallavi, you always excel. You're great. Thank you very much. And I also thank Docs Plexus, who are always with us in these programs. And looking forward to see more of you, Dr. Flavio. And once the COVID is down, maybe we'll invite you again, bother you, ask you to come to India, and maybe we'll have a beer together and have some fun together with some teaching and training.
Looking forward. It was my pleasure. I love to do those lectures because I always learn from you guys, and it's the way to go. We just interact, and really kudos for you for the initiative to create your own database. Is the way to go. Show the world where you are, and the way to do it is just publishing.
Yes.
Thank you.
Okay. Thank you, and good evening and good night.
Thank you.
Thank you, everyone. And yeah, thanks to the Doc Plexus team as well. Sital, Pratish, thank you very much.
Thank you.
Thank you.